Hi, I'm Lisa Lancaster. I'm professor of medicine and director of the Interstitial Lung Disease Program at Vanderbilt University Medical Center. I'm looking forward to talking with you today about the pathogenesis of Group 3 pulmonary hypertension. Thanks for joining. So let's start with definitions. What exactly is pulmonary hypertension in interstitial lung disease? Well, it certainly can complicate many interstitial lung diseases and generally associated with those lung diseases that contribute to hypoxia, with patients showing increased needs for oxygen, worsened shortness of breath, decreased endurance and mobility, and worsened survival. In fact, that's why it's a criteria for transplant referral and listing in ILD. For patients with IPF, the estimated prevalence of pulmonary hypertension is about 30 to 50%. From the World Symposium on Pulmonary Hypertension in 2018, we have updated clinical classification criteria of PH, where pulmonary hypertension types are divided into 5 different subgroups. Group 1 is mainly idiopathic pulmonary hypertension, connective tissue disease, drug toxicity, congenital heart disease mixed together. Group 2 represents pulmonary hypertension related to left heart disease. Group 3 represents pulmonary hypertension related to lung diseases or those things that can cause chronic hypoxia. Group 4 is demonstrable for pulmonary hypertension due to pulmonary artery obstruction, as in chronic thromboembolic disease. Group 5 is a little bit of a mix of different disorders, including hematologic disorders like sickle cell and systemic disorders like sarcoidosis. So what's the definition for Group 3 pulmonary hypertension? From that 6th World Symposium on pH, the definition is the following: a resting mean pulmonary artery pressure of greater than 20 millimeters of mercury with a PVR greater than or equal to 3 Wood units and a wedge pressure less than or equal to 15 millimeters of mercury. So in other words, no impact from the left heart. Severe Group 3 is a mean pulmonary artery pressure greater than or equal to 35 or greater than or equal to 25, coupled with cardiac dysfunction with a reduced cardiac index of less than 2. Before we talk about the abnormal, let's talk about what is normal in the lung, starting with pulmonary hypoxic vasoconstriction. So what exactly is hypoxic pulmonary vasoconstriction? It was first identified in 1894, and it's a homeostatic mechanism that is intrinsic to the pulmonary vasculature and actually works just the opposite of what the systemic arteries do in response to hypoxia. Arteries in the lung constrict in response to hypoxia in an effort to divert blood flow to regions that are better oxygenated and better match and optimize the ventilation perfusion and improve oxygen delivery as a result. That amount of hypoxic vasoconstriction is proportional to the degree of hypoxia and is triggered by a PaO2 of less than 100. It can be impaired by diseases that affect the lung globally, such as emphysema, or even diseases that may cause vasodilatation like sepsis, and is also impaired by vasodilator drugs. HPV more commonly occurs focally in regions of atelectasis or pneumonia or regional disease, again to divert blood flow to areas of the lung where there's better ventilation or better oxygenation. It can occur globally when patients are exposed to reduced FiO2s, such as when patients are at altitude or in global disease states of the lung. The onset is usually within seconds of exposure to the hypoxia, but it can take minutes, many minutes actually, to reach maximal intensity. When oxygen is restored to patients, HPV is acutely reversible. And again, the response is opposite of the systemic artery response to hypoxia, where with systemic arteries, they will dilate in response to hypoxia in order to improve oxygen delivery to areas where it's needed. So one way we capitalize on this in medicine is during thoracic surgeries with one lung ventilation. Selective ventilation of the lung was first described in 1931 and quickly led to more and more complex thoracic surgeries, allowing for that. So those surgeries that may utilize one lung ventilation include BATS procedures, pleurodesis, mediastinal surgery, or whole lung lavage that we may do for pulmonary alveolar proteinosis. And one lung ventilation occurs, obviously so, when deflating the lung that's going to be operated on. So in the normal lung, ventilation and perfusion is well matched, and dependent portions of the lung receive greater blood flow and greater ventilation due to gravity in and of itself or gravitational effects on lung compliance. In one lung ventilation, the lung that's being operated on is deflated, essentially, and the ventilation to that one lung stops. Surgical movement can obstruct vessels, so it can obstruct perfusion. That way, lateral positioning may also change perfusion to that deflated lung as well. And hypoxic vasoconstriction also plays a role to reduce the amount of blood flow to that lung that's being deflated and not oxygenating well. HPV in and of itself may reduce blood flow to the non-ventilated lung by about 40 to 50%. And if you add all of those elements in together, then the actual shunt fraction is reduced to 20 to 30% instead of 50% when you take one lung out of the picture. So what happens when protective mechanisms go wrong, as in group 3 pulmonary hypertension? Well, HPV is typically reversible with oxygen, but when pulmonary hypertension is sustained, it can result in an increased PVR. And that can happen with multiple mechanisms, with global hypoxia related to lung disease itself, reduced inhaled or inspired oxygen, such as with altitude. It can happen with destruction of the parenchyma that can occur, as in emphysema, where there's a decreased number of blood vessels. And as a result, there's a reduction in capacitance of the pulmonary vascular system and ultimately impairment of the ability of the pulmonary vessels to dilate with increases in cardiac output. Also, pulmonary vascular remodeling can occur and result in multisclerosation of the pulmonary arteries.